My name is Darby. I'm going to be the nurse practitioner doing your head to toe assessment today. So I'm going to start with the head, work my way down. So looking at you, I'm just going to note the size, symmetry, and contour of your head and your facial features. Your head is monocephalic, atraumatic. Everything looks symmetrical. Facial features are symmetrical. No abnormal lesions, anything obvious. And then we'll go ahead and we'll just kind of palpate. Nothing felt, no protrusions or any nodules felt on the head. Even hair distribution pattern there. I can go ahead and feel the ears. Go ahead and we're going to palpate the lymph nodes. So we're going to do preauricular, postauricular, occipital in the back of the head there. Do anterior cervical chain, posterior cervical chain. You can do the tonsillar under here, submandibular and submental. Not palpate those, and then feel the clavicle here. We're going to do supraclavicular. Nothing noted there. Okay, so we can go ahead and do the neck since we're palpating as well. So we're going to take note that the trachea is midline. Just going to kind of run my fingers down here. The neck is supple. We're going to do our thyroid exam. So I'm going to slightly displace this way, kind of feel the other side, have the patient swallow. You feel the thyroid isthmus go up. I'm going to do the same thing on the other side. Have the patient swallow. And the same thing. So no nodules, no masses or anything felt there. And yep, everything is midline here. And so now since we are kind of looking at the neck area, we can do our range of motion. So I'm going to have the patient flex, bend his neck down, extend, bend the neck back, lateral bending to the sides, and rotation, which looks good. No restricted movement there, and no reports of any pain. So now we're going to go ahead and do the ear exam, work our way down. So again, we're kind of going to palpate the ears, the pinna and the auricle of the ears. Everything is warm, is pink. No lesions, no nodules noted on the external areas of the ear. For the sake of exam, we'll just do one ear. So we're going to take a look with the otoscope here, take note of the external auditory canal. And then we're going to pull up and back the pinna. I'm going to take a look here. So we can see some cerumen in there, but we can see the tympanic membrane is pearly gray. It is intact. We can see, since I'm looking at the left ear, the cone of light is at 7 o'clock. We can see the umbo, the incus, and the malleus, the bony process there. And no note of any effusion. Again, tympanic membrane is pearly gray and intact. And I'm going to do the same on the other side, but for the sake of time, we won't do that. And we can go ahead and for the auditory cranial nerve, we can do the whisper test. So I'd have the patient occlude the right ear, and I'll come from the back and whisper a two-syllable word.
Apple.
Okay, I'll do the other side with the other ear.
Orange.
Okay. And the patient completed the whisper test and has gross hearing intact. If we wanted to kind of delve a little deeper into conductive, to rule in any conductive hearing loss or sensory neural hearing loss, we could do the Weber test with the tuning fork on the forehead or the René test at the back of the mastoid process of the ear there. So as we're working our way down the head and the face, we can also test the different cranial nerves. So I'm going to palpate the masseter muscle here and have the patient clench, and I can feel good strength, appropriate strength of the masseter muscle, and that tests the motor function of the trigeminal nerve. To test the sensory function of the trigeminal nerve, we're going to take this paper clip has a sharp end and a dull end, and we're just going to test if he can detect the location and the sense of what is touching his face with the eyes closed. So I'm going to touch. You tell me where and what kind of sensation it is.
On my cheek, dull.
Okay, how about here?
Middle of my forehead, sharp.
Okay, how about here?
Chin, dull.
Mm-hmm. How about here?
My cheek on the side, sharp.
Okay, so trigeminal sensory nerve intact. In order to assess the facial nerve, that's cranial nerve number 7, we'll have the patient do different facial expressions. So I'll have him smile, I'll have him frown, raise his eyebrows, pucker your lips, and puff out your cheeks. Good. Okay, so that's the facial nerve there. And then as we continue on to the eyes, we'll be able to assess some of the other cranial nerves. So cranial nerve number 2 is the optic nerve. So that's a fundoscopic exam as well as visual acuity. So I will show this. I will step 6 feet away, and the lower line is 20/20. The patient is wearing corrective lenses, contact lenses. So we'll have him read the bottom line.
LTFPH.
Okay. So 6 feet away. So that was bilateral, and I should have him do covering one eye at a time and try to read. So cover one eye. Same thing.
LTFPH.
You can cover the other eye.
LTFPH.
Okay. So patient demonstrated 20/20 vision with both eyes and with the right eye and the left eye individually. So now I'll test his peripheral vision. So we'll kind of come from above, below, to the side. So I'll have you sit up a little bit. And I'll go from the sides first. Can you see my hands? Okay, tell me when you can see.
There.
Okay, peripheral sides, and we'll do from the top. Tell me when you can see.
There.
Okay, and tell me when you can see.
There.
Okay, so peripheral vision intact. We will also test, so for the fundoscopic exam, that'll test the optic nerve. So we'll do that, and then we'll move on to the other cranial nerves. Okay, so I'm gonna have the patient sit up a little bit just so I can get to him. We'll come from a 45-degree angle, and we're gonna go pretty close up. So we can see the optic disc with sharp margins. We don't see any evidence of any microhemorrhages, any retinopathy. We can see the macula when we were looking as well. And then some of the retinal detachment. Again, for the sake of the exam, we'll just do one side, but we would do that bilaterally and compare them. We'd also obviously be inspecting his eyes. So the sclera are white, the conjunctiva are nice and pink. Sorry. No edema on the eyelids. Eyelashes are evenly distributed and appropriate on inspection there. And we would also note when we're looking at the ears of the symmetry that the inner of the ears lines up with the outer canthus of the eye, which it does. And obviously even distribution of the hair on the eyebrows. So again, that tests the optic nerve, and then in order to test the oculomotor, we want to assess pupils are equal, round, and reactive to light. So we have light here. Okay, so I'm going to come from the side and assess the pupil. So just at baseline, they look about 3 to 4 millimeters. So I'm going to come from the side here. Assess. They constrict to about 2. Same on the other side. And there's direct and consensual constriction of the pupils. And we would also want to test for convergence. So that is when I have the patient focused on my finger. As it comes closer, he's going to continue to focus. We see no evidence of nystagmus or anything concerning with the eye movements there. And we would also want to test for accommodation. So I look at his pupils, have him focus on my finger, and I'll look at that clock in the distance there and then focus back on my finger. And you can see, do it one more time. And I'll do it. So you can see how when he is looking at my finger, that the pupils do constrict, and they accommodate to that. In order to also test the trochlea and the abducens cranial nerves, and that is so the 4 and 6 cranial nerves. We're going to test the extraocular movement. So I'm going to have him follow my finger without moving your head. So only move your 6 cranial views are demonstrated there. We also want to assess the corneal reflex. So I could take, if I had a cotton swab, I could kind of push the lens of his eye a little bit and make sure he has that corneal reflex that's intact. So we did the eye exam and we did those cranial nerves. We did the facial and the trigeminal. So now we'll move on to the nose exam here. So just looking, I'm just going to grab right here. Looking at the nose, again, no visible abnormalities or swelling, no visible nodules. On palpation, nice and warm and pink, and nothing concerning from just the visual exam. So we'll go ahead and take a look in the nose here with the light. And we're looking to see, let me speed up a little bit. Okay, so we're going to look here, kind of pull up a little bit. Turbinates are nice and patent. They are pink. The septum is midline. You can do the same with the other side. Same thing there. Turbinates are patent. They are pink. No evidence of polyps, no discharge noted. Septum is midline. And then I'll have the patient, I'll do the oral exam. So I'm just going to have him say, take a look inside here with our light. Do one more time. Okay, you can see the uvula and everything move up with that, which, and with swallowing, we can also assess the vagus nerve there. And just open, you don't have to say, we're just going to do a little exam so we can see that the mucous membranes are pink, they are moist. His dentition is good. We don't see any cobblestoning in the oropharynx. That would be suspicious of any infection back there. No drainage, no dental caries, no gingivitis, no lesions in the mouth. I'd have him lift up his tongue. We'd assess that down there. The frenulum is intact there. And then in order to, if we were going to test the glossopharyngeal and the vagus nerve, we would want to do the gag reflex. So if I had a tongue depressor, I could test the gag reflex there. But I'll have him stick out his tongue and do movements side to side. And that will test the hypoglossal cranial nerve, which is cranial nerve number 12. And then we will, I think there was one more thing I wanted to do with the heads. Okay, I think that's it for now. Okay, so we'll move on to the cardiovascular exam. So I'm going to just kind of look at the anterior chest. So I'll just have you lift up your shirt just a little bit, just so I can kind of assess the anterior chest. Again, no visual abnormalities, no visible pulsations, and I'm going to kind of feel, my hands are a little cold, but I'm going to just feel the pads of my fingers around the precordial area. Feel and rule out any thrills, any heaves. I'm going to palpate the point of maximal impulse, which is the midclavicular line 5th intercostal space right here. And there's no, again, not palpating any abnormalities. any nodules, any areas of tenderness. So we're going to go ahead and listen to all 5 points with both the bell and the diaphragm. Okay, so second intercostal space, right sternal border is the aorta, aortic area. I'm going to listen to left sternal border for the pulmonic area. I'm going to listen to Erb's point. I'm going to listen to the tricuspid area. And then we're going to listen to the mitral area. And listening for regular rate and rhythm, F1, F2 are crisp. Don't appreciate any murmurs, no extra hard sounds or gallops, anything like that. So we're going to go ahead and listen again with the bell, the same spots. Okay. While we're in this area, we're going to palpate each carotid at the same time. So when I do the carotid exam, you're going to have the patient hold their breath so you don't have interference with the lung sound. So I'll have you hold your breath. And actually, that's only for, I'm sorry, that's for listening for the bruits, but you don't have to hold your breath for this. I got overzealous. And then we're going to palpate. Okay, now when I listen for the, to roll out any bruits, I'll have you hold your breath. And I'm going to listen with the bell. Okay, you can breathe. And hold your breath. And breathe. Okay. All right, so no bruits there when we palpate each carotid artery. So now I will go ahead and I will do the respiratory assessment. So again, when we were looking at his chest when it was exposed, we wanted to see, again, for no visible abnormalities on the anterior chest wall. When he's breathing, we are looking for symmetric and equal chest expansion there. Symmetric movements, no accessory muscle movements. He's not nasal flaring. He's not using accessory muscles, anything like that. He's not in any visible distress. And so I'll have you turn a little bit. And we're going to just measure the thoracic expansion. So I'm going to kind of rest my fingers by the costal vertebral angle. I'm going to have you take a deep breath. And then we're going to see and that's good. We're watching as my hands go out and back in and assessing the chest expansion there. So we'll listen anteriorly first to all the lung fields, and then we'll listen posteriorly. Okay, take a deep breath. Now listen to 4 pairs on the back here. Deep breath. Right, middle lobe, and then we're going to listen to the bases. And everything sounds clear, clear in all lobes, no adventitious lung sounds like wheezing or bronchi, anything like that. So we assessed, again, the chest, we assessed symmetry there, we assessed the excursion of thoracic movements when he's breathing. So now we'll go ahead and do the abdominal exam. So I'll have the patient lay down. Whoever's comfortable. Okay, so can you lift up your shirt for us? Sorry. Okay. We'll make do with what we have. We don't have an exam table, but we're going to do an inspection first, and I'm just kind of looking and looking at the stomach and the abdominal area, making sure that everything looks symmetrical. The abdomen is slightly rounded with no obvious protrusions or masses or hernias. We have a surgical scar that's noted there. Even distribution of hair on the belly area. No striae. We're just looking at the skin, looking for any abnormal, bruising, any lesions, any petechiae, any rashes, and we don't notice any of that. So we can go ahead and do, we're going to auscultate first since this is the abdominal exam. So I'm going to listen to all 4 quadrants and assess for normal active bowel sounds, about 5 to 30 per minute. Okay, bowel sounds are normal active. While we're listening, we'll also listen with the bell to the different arteries in the abdominal area. So we're going to listen to the aorta first to make sure we don't appreciate any bruise. Right below the xiphoid process there. And then we're going to listen for the renal arteries. Bilaterally, no bruise. And then we're going to listen for the iliac. Okay, no bruise appreciated. You kind of use the umbilicus as a reference point while you're going around. So now we're going to do percussion next. So we're just going to percuss for general tympany in the abdomen, making sure there's no abnormal areas of dullness or flatness where there shouldn't be. General tympany throughout just represents, gas in the GI tract there. We're going to palpate for the liver. So you want to assess that the liver span is about 6 to 12 centimeters. So we're going to try to go kind of around. So the bottom edge of the liver should be a subcostal area, and you'll appreciate some dullness where that starts. We'll make our way. Start a little bit. And you feel where it gets dull. So then you measure the liver span there. No signs of hepatomegaly. And I'm also going to try to palpate the liver here. So I'm going to do one hand below and one hand again right below, right in the subcostal area. You should be able to palpate the liver about 1 centimeter below the subcostal area on the right sternal border there. We should not be able to palpate the kidneys. We can attempt to palpate the spleen, which is kind of hard at this angle. But we'll kind of put our hands kind of where the CVA is on the back, and then try to kind of palpate on the left side there. And we can't palpate the spleen. And we will continue the palpation with just kind of doing light in all 4 quadrants. Asking the patient if he has any pain, and then we'll go deep palpation through all 4 quadrants, noting any masses, anything concerning, and then any guarding that the patient has. There's no distension, nothing like that. So we were able to palpate the liver. We did not palpate the spleen or the kidneys. We listened to the abdominal arteries. And then while the patient is either supine or in the left lateral position, as part of the cardiac exam, I should have done it right after, but we could listen to the heart sounds again because some are better to hear in different positions. So we could listen again with the diaphragm of the stethoscope to listen to those areas. And again, I would have done that after the initial, but I had him sitting and then lying down. So, okay, I'll have the patient sit back up. I'm going to assess for thickness in the CVA, the concept vertebral angle. So I'm going to have him kind of get to the back here, get to that CVA, and make sure the patient doesn't have any pain. Any pain there?
No.
Okay, ruled out any CVA tenderness. So we did an abdominal exam, and now we'll kind of move on to the extremities. What we can do is kind of combine some of the musculoskeletal and neurological exam portions, and also palpate the pulses, which is a part of the peripheral vascular exam. So I'm going to look at his hands. They're nice and pink, and they're nice and warm. Assess capillary refill, brisk, less than 3 seconds. I'll assess for his grip strength. This is a neurological test, so I'll have him squeeze my fingers. Very good. I'm going to palpate pulses here. We're going to palpate radial, brachial pulses. Okay. And since we're on the arms, we'll continue. We'll do passive range of motion and active range of motion to test the muscle groups. So, go ahead and straighten his arms, and then we want to assess for pronation and supination. And then I'm going to just relax your arms, and I'm going to just bend your elbows. We're going to test passive range motion, and then I do want to test for active range motion to assess any muscle weakness in the biceps and triceps. So I'm going to have him push as he is flexing. I'm going to flex your arms and push against me as I try to. I guess your inflection, go to extend. I'm going to push against you. Okay, great. And then the opposite. Great. Hard to explain. Okay, so 5 out of 5 strengths there. And then I'm also going to assess if he's able to have, he has appropriate range of motion of the wrist, so we'll have him flex the wrist, extend the wrist, over deviation and radial deviation. Very good. We're going to assess the grip strength there. We'll test the shoulders next. So I'll have you, it might be a little bit easier standing, so I'll have you stand. Okay, so you're going to flex your shoulders, extend your shoulders, and then you're going to adduct and abduct, internal rotation and external rotation of the shoulders. Good. And then if you can see here, I'm going to test the spinal accessory muscle by having him shrug your shoulders against resistance. Great. That's cranial nerve 11. And then we are going to have him do the hips now. So we're going to have him flex the hips. You can see here, extend the hips by bringing the leg back. And then I'm going to have you abduct the hips and take it to the side. Adduct and bring it in front of you. And you would have them do that on both sides, but for the purpose of the exam, we'll just do one. Okay, and then while we're doing the legs, we're looking at the legs and just doing a general inspection, looking at the skin, looking that it's pink, it's no edema, no visible deformities. And as we're doing all of these, we're kind of just palpating the joints here. And then we're going to take a look at the feet. I'm going to have the patient sit back down. And we're going to do capillary refill in the toes, brisk, less than 3, palpate the dorsalis pedis and the posterior tibialis. And then, you know what, and when I had you stand, I meant to, we can do this while you're sitting, but I'll have you flex your knee if you can while you're sitting, and then extend it, bring it back. Good. And then I'm going to have you dorsiflex, which is pointing the foot up, and retroflex, put the foot down, evert, bringing it to the side, invert, bringing it in. And we're going to do a couple tests for meningeal root irritation, or just one. We're going to do the Keurig's test. I'm going to have you lie down. And I'm going to have you bend this knee. And we're going to be 90 degrees and 90 degrees with the knee and the hip. And we're going to have the patient have this leg straight. The patient complains of any irritation in the spine area, any pain. Their neck kind of wants to flex back or flex forward, and their opposite hip wants to flex. That could be a positive sign for meningeal irritation. For any radiculopathy of the leg, we can do a straight leg test. So I'm going to have the patient straighten this leg back out. And then I'm going to lift the leg and make sure that he does not complain of any pain going down the leg or any pain in the lumbar area, because that could be a sign of radiculopathy in the leg. And I'll have the patient sit back up. We did active range of motion tests, which could assess for any muscle weakness. We will then do some neurological tests. I'll have him, we'll do some cerebellar testing by having the patient stand up. And we will assess with the Romberg sign, and we'll have him close his eyes and get arms to the side. And you assess for any swaying for about 20 to 30 seconds. And if there was some swaying, that'd be a positive Romberg. But cerebellar function for this aspect is intact because he appears to have, he's not showing any movements when his eyes are closed there. We're going to assess his gait, so you can open your eyes. I'm going to have you take a couple steps that way. We're going to assess the gait, normal stance and stride, very coordinated. So that is one other neurological test we could do. When the patient is walking into the room, we could assess that. We want to assess for rapid alternating movements. So we could do that with the hands and just have him this. You do the finger, touching a finger to your nose and finger. Yeah. And you can also do finger to thumb, rapid alternating movements, fine motor coordination there. While the patient is standing too, before we do deep tendon reflexes, we'll assess the spine. So I'll have you turn. I'm going to lift the shirt up so I can see a little bit better, but we're going to palpate down the spinous processes, making sure there's no deformities. The spinous processes are straight. The alignment of the spine is appropriate from the posterior view here and from the lateral view. The curvatures of each part of the spine are as they should be. And all of his, we're palpating again, those joints, the shoulder joints, the hip joints, and then the knees, and assessing again for no deformities or edema or pain or erythema whenever we're kind of palpating those joints. We're going to test the range of motion of the spine by flexing forward. Okay, and then extend back. Twist to the side gently, twist to the other side, and lateral bending to both sides. Okay, very good. And now we're going to end with the deep tendon reflexes. So probably be best to have you sit on the edge here, and we'll move the. So we're going to do brachioradialis. We're going to find the brachioradialis tendon, and then you're going to assess for movement there. You do it bilaterally. And then for the, actually I'll do it here, so it's a little easier. For the brachial, it's the medial aspect of the AC fossa here, and you're going to assess for a brachial reaction there. Kind of hard angle, but we'll have that. And then we'll do the triceps and have them kind of really relax that arm, find the tricep tendon there. Expect the extension of the forearm there. We'll do that. So that's brachioradialis, biceps, and triceps. And then we're going to go ahead and have them try to slide and relax that knee to do the patellar tendon. And find that patellar tendon here and do a brisk with the part of the hammer there. And then we will do the Achilles with the blunt part. Find that Achilles tendon, swift movement. And you watch that. And actually, when you're doing that, you'll kind of put the foot in dorsiflexion a little bit, and then you'll be able to appreciate that more. And then we'll do the Babinski's, where we take the sharp point and we do the lateral aspect of the foot and drag that toward the great toe. And then we assess for curling of those toes, and that's a negative Babinski there. So we did all the deep tendon reflexes. And the only other thing I'm going to do with the foot is just to assess for any neuropathy in the foot and make sure that he has intact sensation of the feet. So I'll ask him to tell me what kind of sensation, sharp or dull, and where he's feeling it in the foot.
Under the big toe, sharp.
Okay.
Towards the heel of the.
Yep. Okay. So we're going to test that, that tactile sensation on the bottom of the feet. We do both feet. And we already felt the pulses, and we already kind of inspected the feet. And the only other things that we can do for the bony prominences of the feet and the hands, we can test for vibration. So we have this tuning fork here. And then I would ask the patient to tell me when he feels the vibration stop. So I would do that on the bony part of the toe, ask him to tell me when that stops. Okay, and that's when I felt it stop. Last parts of the neurological exam, we can do the stereognosis, which is patients able to tell what is in their hand with their eyes closed. They have that sensation of that object recognition. So we're going to have him close his hands. Open your hand. Tell me what that is.
Key.
Okay. And then I'm going to have him tell me what this is.
It's a pen.
Okay. And then we're going to also do the graphesthesia, and then we're going to trace the number on his hand. And he's going to tell me what number I was tracing.
3.
Yeah. Okay. And probably would have done this at the very beginning, but to just kind of do like a mini cognitive assessment, we can just ask the patient questions that confirm that he is A and O times 4. So we'd have him tell us his full name and his birthday. You want to do
John Smith.
What's his birthday?
July 4th, 1993.
Perfect. And where are we right now?
We are in Wilmington, Delaware.
Okay. And where, or what month and year is it?
It's November 2023.
Okay, perfect. And then he's appropriate to the situation. And we could just assess his general cognition there. I know I'm a little bit over time, but I think I did everything that I wanted to. All right. That's the head to toe assessment. Thank you.